bringing together voices in child and youth healthcare. This is CAPHC Presents.
CAPHC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, the McMaster Children's Hospital Foundation, the Children's Hospital of Eastern Ontario Research Institute, the Children's Hospital Foundation of Manitoba, and the Montreal Children's Hospital Foundation. We would also like to thank the following Keystone partners for their ongoing contributions that support all of CAPHC's programs and activities. Hello, everyone, and welcome to today's episode of CAPHC Presents. My name is Doug Maynard, and I'm the Associate Director at CAPHC, the Canadian Association of Pediatric Health Centres. All right, so let's get on with today's session. Today's webinar is titled Shit Happens, a Parent-Led Initiative Using Social Media in Hirschsprung's Disease, and I can honestly tell you that I will be very glad when I don't have to say shit happens in a professional context anymore. I've gotten quite a few responses every time we've mentioned that during the promotion for this webinar. Certainly generated some interesting conversations. And this topic has come to us once again, similar to last week, from one of our knowledge translation partners, this time from our colleagues from the Children's Hospital Foundation of Manitoba and the Children's Hospital at the Health Sciences Centre in Winnipeg. And we're very excited to share some of this great work from this research group from one of our members and our partners. Our panelists did want me to mention that just to reinforce that this talk is about the project that they're doing and to have an open dialogue about the topic, but it's not a venue to seek medical advice from any of the healthcare professionals that are on the panel. All right, so I'm on to introducing our panel. We do have quite a few folks here, but they're all in one room, so they're going to be sort of trading off the conversation throughout the session. So we're going to, first off, we have Dr. Christy Whitmire, who is one of the lead researchers for the project, and Christy is a physiotherapist researcher and the Director of Knowledge Translation at the George and Fay Yee Center for Healthcare Innovation. And Christy did not put in her bio, but she's also a member of the Knowledge Translation and Research Committee for CAPHC's Rehab Network, the Canadian Network of Child and Youth Rehab. Then we have Dr. Richard Kaiser, who is a pediatric general surgeon at the Winnipeg Children's Hospital and works with families that are affected by Hirschsprung's disease. We have Cindy Holland, a nurse practitioner and co-investigator on this project. Cindy's at the Pediatric Surgery Service at the Winnipeg Children's Hospital. And we have Kendall Hobbs-Murison, who's a nurse and research technician for this project. She has 10 years of clinical experience at the Pediatric Surgical and Burn Unit at the Winnipeg Children's Hospital. Then we have Dr. Melanie Morris, who is also a pediatric general surgeon, recently joining the Department of Surgery and Urology in Winnipeg. And finally, we have Liz Crawford, who is a mother of a child with Hirschsprung's disease, and she was the inspiration and creator behind the Shit Happens campaign. Liz has a public relations company, Swish Productions, that she owns and runs. So it's my pleasure to hand the virtual podium over to Liz to kick off this session. Over to you, Liz.
Thank you, Doug, and thank you to CAPHC for inviting us to participate today. I will take full responsibility for the name associated with the campaign. Definitely was all me, so nobody else is on the hook for that. Okay. So my son Malachi was born in 2008. When he was born, he spent the first month in ICU. And, it took some time for us to find out that, God, that kid's cute, that he had Hirschsprung's disease. Once he was diagnosed with the disease, that's really sort of when I noticed that there was a hole in information. And that was kind of sort of the beginning of this adventure. I started, of course, researching what is Hirschsprung's disease. What does the future look like? What happens post-surgery? And there is information out there, but most of it is, until they have surgery. So it was really a really hard time for my family, and subsequently Malachi's had over 20 hospitalizations with complications of Hirschsprung since. So it was when he was about 2 years old that, I really sort of recognized that if I have this need for more information, then other families would have this need as well. And how do we go about finding out more information? And our surgeons here have the patience of Job, but my text messages at 2 in the morning were probably starting to get tired. So I decided it was probably a good idea to maybe reach out to other families because they too are living with this disease. So that was when I decided that it would be fun to start a parent support group, the Hirschsprung community. And of course, I do own a public relations company. We do work in fashion marketing, and I own a modeling agency. So pulling in all of my resources, we created the Hirschsprung community and a Twitter account and a blog. And we decided that the best way to attract families with, who either have Hirschsprungs or a family member with Hirschsprungs is to create a campaign. And in my experience, when you're trying to grab the attention of people, a catchy slogan on a T-shirt on some supermodels, it's always a win-win. So we, enlisted the help of a lot of friends. Silver Jeans created these T-shirts for us, and our friends over at Direct Focus did all of the campaign slogans, and that's how that campaign kind of came to light, and it really worked. I think once the first image went on Victoria's Secret Supermodel, Dr. Kaiser's favorite, Do It to Chris, and I know he says it properly, it really went viral and caught the attention of not only families, but also medical professionals and people within the community. So that's kind of a little bit of background on the why of the social media and the campaign and the sort of how we did it. It was really sort of a joint effort of basically everybody I know getting in and sort of getting the word out there to attract families. Since then, we've had lots of great celebrity support as well, and so that's been a really sort of fun aspect of it. And people will ask me about the name Shit Happens, and often wince. But if you are a mother or a parent who has a child with this disease, it is ironically the most incredible moment when it does happen. So instead of focusing on, how it isn't happening, we really wanted to take that moment that all families can relate to. You have a child who most often we hear that, kids with this disease suffer from chronic bowel obstructions and constipation. So when that does happen, you are, believe it or not, overjoyed and ecstatic that it's actually happening. So that was kind of the reason why we decided to go with that name. And then, of course, since then, it's really snowballed. It is a very active online community, and the blog has many followers from all over the world, and it's really become a great foundation for family support. Then, in 2011, I think, is that when we all got together? It really sort of grabbed the attention of this group here, and Dr. Kaiser and I started to talk about it, and he really saw opportunity with having this pool of patients and families. And so that's really when that happened. And at the same time, I also met another group out of Boston, Mass General, who led by Dr. Alan Goldstein, and was invited to take part of a new foundation being set up for Hirschsprung called REACH. So now it has become, it's went from one catchy little slogan on some supermodels and a family support group to really being integrated. And REACH now is also a part of that entire system, and REACH sort of acts like the more information sharing, more on the legit medical basis. It's a website that physicians contribute to, less families, and then the rest is sort of a family support network. So that's sort of the history of how we got there. It started with obviously my son and in my understanding of the needs, and then all of these amazing people that came together to create the community, and then it's just kind of snowballed from there. So I think...
Okay, thank you very much, Liz. My name is Richard Kaiser. I'm one of the pediatric surgeons, and I'm presenting on behalf of Dr. Morris, who is also a pediatric surgeon in this children's hospital. So we thought we would also give a little bit of background on Hirschsprung's disease. So on the left of this slide, you see a picture of Harold Hirschsprung, who is a pediatrician from Denmark, and who was the first to describe Hirschsprung's disease in 1886. And on the right you see a section of an intestine that is affected by Hirschsprung's disease. So Hirschsprung's disease occurs in about 1 in 5,000 newborns, and the underlying cause is that there's abnormal innervation of the large intestine that causes stooling difficulties in the babies born with this disease. Most children present right after birth with difficulty to pass meconium within the first 24 to 48 hours. then the pediatric surgeons are getting involved, and they will make a diagnosis using a contrast study with the help of the radiologist and by doing a biopsy of the rectum. So as Liz was already alluding to, we got familiar with her campaign in about 2011, and she started her blog and Facebook campaign and Twitter campaign, and we became involved because my interest in Doutzen Kroes as a Dutch pediatric surgeon, I was well aware of her existence, and this campaign being endorsed by this model really helped to get our interest. So we started to do some research within the online Hirschsprung community, and as a kind of a pilot experiment, we asked Liz to pose a question through the online community. And the question was, at what age was your child potty trained? Within 2 hours, there were 143 views and 20 responses. And within 5 hours, we had 30 responses from this worldwide community with parents and patients with Hirschsprung's disease. And what we had now established within a day, actually, was survey this community internationally, and we were very impressed with the responsiveness and how fast they were responding to our question. However, we also became quickly aware that there's no real healthcare provider interaction with this community, and that's why we wanted to see if we could help Liz with her campaign a little bit. So we started off with a survey an online survey of the Canadian Association of Pediatric Surgeons. About 25% of all members responded to the survey, and we asked them what kind of problems they run into in their daily practice as a pediatric surgeon when they deal with patients and families with Hirschsprung's disease. And their priorities included stool patterns, bowel management, treating perineal irritation, recognition and management of enterocolitis. One of the unique problems that pediatric surgeons identified that was how to make the diagnosis. The other interesting thing from this survey, what we found, was that more than 80% of the pediatric surgeons use their own expert opinion or their colleagues to guide management. 3/4 used guidance from the literature, but only 25% provided care through a multidisciplinary clinic, and only 1/3 relied on practice guidelines and protocols. So we thought there was a huge gap for evidence-based practice, and that's why we then started our research project with the Hirschsprung's community, and Kendall will talk a little bit more about that in the next part of the presentation.
So it says Cindy Holland baby backup because today is actually my due date. So Liz and Dr. Kaiser have described the beginnings of how we got here. We will provide a bit more detail on the project itself. From this point, we worked to formalize a collaboration on this. A letter of agreement was formalized with Liz as our parent partner to establish a working relationship as part of a core research team. Our first step was to share the analysis of the reach and responsiveness of this virtual community, and after some time spent in the publication process, this initial analysis was published this past December by the Journal of Medical Internet Research. This was very well received, scoring 4th and 96% at the time of release in respect to popularity. This is the map from the initial campaign analysis, which gives you an idea of how this has become truly global. At last record, there were 176 Twitter followers, over 5,000 blog views, 1,130 Facebook monthly users. What we concluded at that point was that social media networks were well suited to discussion, support, and advocacy for health-related conditions and could be especially important in connecting families affected by rare conditions. with this campaign demonstrating the reach and responsiveness of a community that primarily relies on social media to connect families affected by HD, and that although responsive, the community lacks access to evidence-based guidance for their common concerns. With our parent partner coming to us with a potential risk of transmitting erroneous information through this venue, we wish to expand on this. So raising the research question, can integrated knowledge translation, which Dr. Wimmeyer will talk more about later, be used to guide research questions in rare diseases? So we first sought approval from our University Research and Ethics Board and our Hospital Impact Committee, with Liz clearly identified as a co-investigator. In a collaborative effort, we embarked on a research study. Our primary aim was to use social media to prioritize information needs of HD families, and our secondary aim was to compare congruency between information needs of HD families and the pediatric surgeons. So what did we do? We surveyed the families participating in this social media community regarding their perceived needs, and the second, the pediatric surgeons through their Canadian Association, surveying them about their most common problems encountered, and at a later date regarding which methods they use to guide such management in their HD practice. We took the responses from the two groups, then deemed them separately at first, then analyzed them for any like themes of luxury. We were also able to compare them to a priority list generated from Google Analytics pre-survey. And then using a fancy term we call the modified Delphi approach, which was rounds combining face-to-face meetings with anonymous email surveys to rank needs. We formed a consensus on a priority list of caregiver-informed needs that we could use and take forward. Some pertinent demographic data from the family survey includes the age of diagnosis, which captures mostly those with an early diagnosis, ensuring we are not reflective, for example, of only late diagnosis. Family indication of the type of HD is representative of what's found in the literature, and family satisfaction of the current resources confirms there is room for improvement, with the majority, 42%, indicating they are only somewhat satisfied. In reflection of the quick and responsiveness, 66% of the family surveys were completed within less than 7 days from the survey going out. This is an infographic created by the Center for Healthcare Innovation, a family-friendly format that we use to feedback the survey results to the social media community. In the pink are the family results, and in the blue are the surgeon's results. 89 surveys were complete by families, and 52 surveys were complete by surgeons. Please see the ranking of the issues in the dots. We can see that the family priorities are reflected by the surgeon's priorities, with shared priorities in bowel management, infection, and perianal irritation. Other priorities for families were nutrition and growth, with rare mention by surgeons, and GI pain. While you can see the surgeons were more concerned with surgical complications, as well as how to diagnose HD and how much colon to remove. So we used these top 7 to guide our literature search. So at this point, we concluded that IKT research combining the parent research partner with social media can identify and prioritize knowledge needs for families dealing with rare diseases such as HD. We are now working to address these needs. Here at HSC, we are only seeing about 5 cases of HD a year. Hence, we are collaborating with international experts on this matter to push this research agenda from the family's point of priority and work towards achievable goals to better the care we can all provide. We've presented these results back to the surveyed surgeons at their annual meeting and their associated nursing interest group for feedback this past fall. An infographic was presented back to families through their virtual community, asking for their evaluation, which Christy will talk more about. We have collaborated with REACH, the nonprofit organization titled Research, Education, and Awareness for Children with HD that Liz has talked about. And we are working to conclude a series of rapid reviews to identify relevant evidence. If you are unfamiliar with rapid reviews, this is a systematic search of the literature to get evidence as quickly as possible. Targeted experts will be surveyed a second time for their expert opinion of the identified issues and included as part of this rapid review. The overall intent would be to contribute to the creation of recommendations for managing the 7 priority issues. Any knowledge tools derived from this will be widely shared, seeking again our stakeholders' input. Gaps in evidence will be compiled and shared with clinicians, researchers, and others interested in HD. There is potential for application to other pediatric rare diseases that deal with chronic management issues. We have shown we have efficiently used social media to engage patients to guide the direction and priorities for future research in a rare disease, improving the relevance of evidence-informed information that we seek to provide. Now, Christy will talk a little bit more about the knowledge translation using social media piece.
Excellent. Thanks, Kendall, and thank you, everyone, for your participation in this webinar. Maybe I'll just stop here, and Doug, do we have any questions that anybody wants to ask before I get into the KT piece?
Any questions yet, but I'll just take this opportunity to remind the audience to type in any questions as you think of them, and as we switch between these presenters, we'll make sure we inject the questions if we get any.
All right, so if there are none, then I'll just continue on and feel free to speak up with questions. So I get to talk about the knowledge translation perspective for this project, and as a physiotherapist by training, I wouldn't have normally been involved, but through my role at the Center for Healthcare Innovation, I've had the privilege of working with this team. I thought I'd start with a brief, simple definition of what is knowledge translation for those of you who may be less familiar, but unfortunately there's over 100 terms used to refer to knowledge translation, so it's not so brief and easy. I think it's mostly a Canadian term, although it's been used in other places as well, knowledge translation, or KT, but it's also referred to as dissemination or uptake, utilization, translation, and mostly referring to research or evidence, of course. The Canadian Institutes of Health Research here in Canada have agreed upon a definition for knowledge translation that's being more and more taken up across our country that refers to the dynamic and iterative nature of KT. It points to the fact that it involves everything from the synthesis of evidence, as Kendall mentioned, we're doing rapid reviews to synthesize evidence, right to dissemination and exchange. We're talking about the ethically sound application of knowledge and generally looking at improving the health outcomes for Canadians or citizens, patients, and members of the public. The really important thing that I think we're emphasizing in knowledge translation now, and I'll speak to this in a moment a little bit more, is that it acknowledges the complex set of interactions that occurs between researchers and those who use the knowledge or could be using the knowledge that we're producing. I like to boil it down to 2 simple concepts, especially relevant to this project. I like to think of KT as producing relevant research and ensuring that evidence produced from the research gets to the right people in the right way. So a little bit more on what we think about knowledge translation as typically I think academics would be familiar with presenting their work at conferences to other academics or clinicians perhaps, or publishing in a journal again to other academics, and we're now calling that end of grant or end of project knowledge translation, and realizing there's a place for it absolutely, but also the limitations of just presenting our work to other academics and clinicians. And we're moving in this exciting direction toward integrated knowledge translation that Kendall spoke to briefly before. And integrated knowledge translation speaks to that importance, as mentioned on the previous slide, of involving your stakeholders, the people who know what questions need to be asked for a certain condition, and that might be the patients, the parents, the clinicians, or the researchers, of course, too, who can benefit from the information that will be produced from that research, and then who can make decisions to improve care. And for every project, we can think about who those people might be and ensure that we're involving those people in our work. So why is this project so interesting from a KT perspective? Well, it's interesting for a lot of reasons, but I mean, let's talk about the elephant in the room maybe and start with the attention-grabbing name. If Liz wasn't here, the project wouldn't have happened because she was such a central force to creating and moving this initiative forward. But B, I think as researchers, we would have probably called it something like integrated knowledge translation to communicate information to families and patients with Hirschsprung's disease, or something equally long and complicated that would have made perfect sense to us, but would not have been engaging, probably would not have resonated at all with anybody affected by Hirschsprung's disease, and certainly would not have fit on a t-shirt. So a lot of limitations to the way that we would have maybe marketed this project. And I think personally that knowledge translation can learn a lot from marketing, and the fact that this campaign has gone global has resonated so strongly with the community. There's comments on the social media venues all the time about, finally someone gets it, or I love the sense of humor. This name really resonates with me. So as much as it might get some people's back up, it really resonates by the people affected by the condition, and I think that's what is really critically important about this campaign. This campaign and marketing has so much influenced me that at the Center for Healthcare Innovation in our KT platform, we've in fact hired somebody with a marketing background. I think it's just so essential to learn from people outside of our typical research and healthcare training. We also know, so beyond the name, that people are searching for health information online. I think it's probably even higher than the number I was able to find here, but we know that a lot of people go to Dr. Google if they have a diagnosis or have a rash, have anything. The first touch point for healthcare advice often can be on the internet. So we have to think about, as researchers or clinicians, are we out there and helping ensure that evidence that people are finding is based on research and of top quality. And then, of course, the two key aspects that are particularly interesting in terms of knowledge translation are the fact that this is a social media-driven campaign and a parent-driven campaign, and I'll talk about each of those two items a little bit more. So social media, the marketing was key, but the social media aspect of it allowed for this campaign to go global. Kendall mentioned that we see about 5 families a year that would come through with Hirschsprung's disease here in our hospital. So you can imagine a paper-based survey would take a really long time to collect. If all 5 people consented over the course of that year, we would still only have 5 at the end of the year. Where this campaign was able to go global, and we have a really engaged community, and such a rapid response because of the engagement and the ability to interact over social media with one another and with our research team as well. And this speaks to something kind of exciting, kind of new in research anyway, to research prioritization. There's other methods that we're learning about and that are becoming established in terms of prioritizing research questions. The James Lind Alliance is one well-recognized approach. That approach is rigorous, it's wonderful. It can take up to a year to complete it, and it involves a lot of travel in some cases, face-to-face meetings, and other processes. We were interested in how we might harness the power of this crowd, the public, engaged community, to help prioritize research questions for Hirschsprung's disease. So just a little bit more on crowdsourcing from these authors who published in the Journal of Medical Internet Research as well. And they talk about crowdsourcing, or getting that input from the crowd, and usually online, to test or develop health messages. So moving from the use of crowdsourcing in business world, Lego crowdsources, Starbucks crowdsources to get input on their products. Why can't health clinicians, health researchers crowdsource to get direction into where we should take our research? I think there's a lot of potential there, and it could be a topic of a whole other presentation, but I'll just leave it there for now. The other aspect that was of great interest from the KT perspective, and particularly the integrated KT perspective, was that Liz really drove this project. Where do our research questions typically come from? It varies from area to area and researcher to researcher, but a lot of the times it's not coming from our communities who are living with the condition. I should say at this point maybe that integrated knowledge translation is not a new concept. It's practiced very well by many different researchers, and in certain areas community-based research especially. It's been done for a long time, but we're seeing a trend that is going across basic to community-based research. But the parent-driven aspect of it is unique, is fascinating, very exciting. And what I have a picture of a ladder on the slide for is to show this ladder of citizen participation that's been proposed by Arnstein. where they talk about at the very lowest rungs, we may involve patients in a tokenistic way. And I would say that's what we want to avoid at all costs, is involving people in research in a way that they really can't have any impact in where the research is going or what direction it takes. As we move higher up the rungs, we get into the more consultative or collaborative types of participation and engagement, and at the very top is citizen control. So I think for this project we're looking at a mix between collaborative and citizen control type of participation, and it's been a wonderful experience to see how the research moves along when a parent partner is leading it. Having someone as invested as a parent driving the research as well really speaks to these 4 different elements of avoiding research waste, a concept that was put forth in the Lancet a few years back now by Chalmers and Guazou. And the 4 areas that they propose that research waste can occur are in the question. Is it a relevant question that's being asked? If not, there's waste. Are the designs and methods appropriate for the question? Is the publication accessible, and is the report actually usable? And by having Liz and the community, the Hirschsprung's community, involved in this research project, I think we've really avoided a lot of research waste and ensured that our project is in fact usable. And I just have the infographic up there again to demonstrate that point of the usable report. We had Pat Fauché from our platform put this together and ask people, is this usable? We think it looks great, but what do you guys think? And of the 97 people who responded to us, 94% of them understood the information very well, agreed with the priorities. So it was a wonderful way of validating that we got it right, and agreed that they want to see information like this in the future. So there was a lot of positive feedback that we were interacting, we were feeding back information in a good way, and they wanted to see that continue. I think the only downside of sharing the information was that people wanted to know, well, what are your answers? And we haven't quite gotten there yet. We're just wrapping that up. So it's great. It shows again how engaged people are in this project. It's been an extremely positive experience. I've learned a ton. I think we all have, and hopefully we're producing something that will be very helpful for this community in the end. But of course, there's been a few issues from the research side of things that we've had to kind of troubleshoot as well. We're using what we kind of have been calling a hybrid model of new and old research methods, or even new and old knowledge translation methods, where, we're using survey-based survey to get the prioritization occurring, but we're doing it over social media. So the response is very fast, but we still have the traditional processes, ethics, approvals, and whatnot that we have to go through to get the information back to people. And we still don't have a way of producing a rapid review on a topic within a week, which I think people would have probably appreciated, but just not really feasible. There's a need when you're using social media to quickly respond from our research team, from the healthcare providers. For example, there was a link that wasn't working properly for some people in completing the survey, and in previous conversation with our research ethics board, they had wanted or preferred that we have all tweets approved by them before we post it, and that really hinders the responsiveness and the speed and rapidity of response that you can have on a venue like Twitter. So it's really essential that you're working alongside your research ethics board prior to implementing a project like this and throughout the project to make sure that these problems can be resolved as quickly as possible. But of course, those are small issues in the grand scheme, and it's been, again, a fantastic project to work on from the KT perspective. Especially, I've found it fascinating, and I do believe that we've been able to get at that relevant research for people who really can use it and ensure that that evidence gets to the right people in the right way. I'm going to wrap it up there. I'm just going to hand it back to Richard for some final thoughts, and then hopefully you guys will have some questions for us to answer. Thank you.
Yeah, thank you, Christy. That was great. So I think that was a great overview of our project, and as Christy already explained, we're still trying to figure out the methods. It's been a very interesting experience. I would like to give some thanks to all the people on the team who worked on this project, and in particular also to the Hirschsprung community, the families and the patients that helped us with this campaign and with this research project. I'd also like to thank our funders, the Torrixon Chair in Surgical Research, the Children's Hospital Research Institute of Manitoba, and the clinical earnings of the GFT members from the Department of Surgery in the University of Manitoba. This is a picture of our team, and also the link to the overview of this project, and a link to the REACH website that provides a lot of additional information on Hirschsprung's disease. And as Christy said, we would be happy to answer any questions.
All right. So as our speakers have said, please do let us know if you do have any questions. We do have a few coming in now. The first one that came in is from Barbara, and she says, did the REB, the Research Ethics Board, really indicate that they should approve all tweets? And how was that supposed to work, and how does it work now?
So I'll let Christy answer that question.
Hi there. Yeah, that was kind of our response too, was, are you really wanting to approve all of the tweets? And I think we just had to do a lot of clarification about what we were going to be tweeting. So if it was a troubleshooting versus getting information out, they really wanted to make sure if we were giving a summary of our research findings that they looked at it to approve what we were putting out, making sure it wasn't it was portrayed in a way that they would be happy with. What was fortunate was that Liz, as our parent partner, was able to do some of that troubleshooting, responding to broken links and whatnot. We found a way that was acceptable to our team as well as to the Research Ethics Board to be able to troubleshoot those immediate issues without having to go through ethics. And everyone was okay with that. But I think it's still a conversation that we're continuing as our ethics board becomes more comfortable with the use of social media, and we have to understand as well what kind of material that they're comfortable with.
Thank you. We did have a few comments about or questions about any negative impacts associated with the name. I mean, I can tell you that we send our information out about this webinar to about 5,000 people a week or a little more, and we had one response back saying that they felt that the title was inappropriate and they didn't think that was very professional. So 1 out of 5,000 is great. But was there any sort of negative impact of having this name? I mean, it does attract a lot of attention, but was there a downside to it at all?
I'll speak to that a little bit first, and then I'll ask Liz if she has anything to add to that. We presented this at a couple of conferences, and one time I, as the lead author on one of the abstracts, was told by one of the senior members of that association that it was completely inappropriate to put a title like this in an abstract book of such a highly respected organization. And I explained to that person that we just wanted to pay tribute to the campaign and to the community, but he didn't accept that as a good explanation. The other negative interaction we had was when we submitted the first manuscript, pretty much describing the project and describing the campaign, to one of the more established journals. We got a letter back from the editor, the editor-in-chief, that they deemed it inappropriate to submit a manuscript to their journal with the word "shit happens" in the title. So we did change the title afterwards when we submitted it to the Journal of Medical Internet Research. But yeah, so there have been a few people responding negatively to the title. At the same time, I think if it wasn't for this controversial title, it would not have probably attracted so much attention. So I think it's still, and I think Liz is probably the best person to explain again why she used this title for her campaign.
Okay, well, it seems to be the hot topic of conversation today, as I did a radio interview this morning, and I'm quite certain the radio host didn't realize when he asked me repeatedly to name the campaign what it was. So it left him a little flustered. Well, first of all, I work in fashion, so it's going to take a lot more than this to shock anybody in my world. So it was definitely a learning curve doing this project with this group, because obviously this isn't my world. But as far as families go, I think that the name has been really well received. I've had 1 or 2 comments and some suggestions that we change the word to poop happens or it happens or, something of that sort. But the truth and the reality is this: it would not have the impact that it does. And, when you have a child with Hirschsprung's disease, and, honestly, the moment came from my son was in the hospital for probably his 12th bowel obstruction, and my girlfriends were all there. There was a small army of, stiletto-clad, ex-models. They're there and they're all in, and we're standing around, and he hasn't voided in. We've been in the hospital now for over 24 hours. And we've tried everything, and finally he does. And honestly, it's not for the weak at heart. I mean, we've often joked about, going in wearing hazard suits or whatever those are called, hazard suits, because you need one. And it was like once he went, it was dead silent. So one of my girlfriends just perked up, we're all covered in it, and just said, well, shit happens. And it was just that moment, that incredible joy. So for most families, they really do receive it. They get it. But the odd one has said to me, don't you think it's inappropriate to make light of it? And it's really not making light of it. If you have a child with Hirschsprung's, you understand that moment. So yes, a little negative feedback, but out there in the community and even in mainstream media, it amazes me how many, magazines, television shows have been on live TV, radio talking about it, and they have been, the guy this morning was hysterical. He thought it was great. So for the most part, outside of these walls, people really like it.
Folks in the audience who like it too, there's lots of comments and LOLs and smiley faces being typed in, so there's lots of support. And in particular, a comment from Kelly, who says, I love the name. My daughter has HD, and we always use that statement whenever something, and she has something in quotes, whenever something happened. And it really is a true statement of how life works in the HD world. So she says, good for you, keep it real. And I wonder if I was sort of thinking that, it's one of those things that, in the healthcare world, and we communicate at CAPHC, of course, with the hospitals and the sort of the traditional old school healthcare sector all the time. And we often even still run into email filtering within an organization that will filter out emails that have keywords in them. So if it has a word like shit in the email, I'm suspecting that we have a lot of our members that wouldn't even have been able to receive our messages that had this title in it. So it's just interesting in that this being a parent-led initiative allows you to do that sort of stuff, but it also highlights the chasm between the family's experience and the traditional sort of old-school healthcare world that still has some of these objections just based on simple language like this.
Yeah, we couldn't agree more.
Mm-hmm. We did have a question from Diane who's asking, is Liz, as a parent that's involved in this research initiative, is she paid for her work on this initiative?
Hi, good question. No, I'm not. All of the work that I've been doing for this project and other projects in REACH is all volunteer. Because of the popularity of the campaign and all of the projects and initiatives that have come with it over the last couple of years, we at REACH have just hired our first staff member. But no, all of us involved in the project, we're not paid for it.
And are you talking about the campaign or sort of the subsequent research project that came out of it?
All of it. I mean, it's all for me, volunteer.
Yeah, and I know Diane, and she's in the research world, and I wonder if she's just asking about the concept of engaging families in research in this way. If pay is a requirement to really fully engage families for their work and compensate them for their time.
I think Christy's actually going to answer to this. Is that aside from this experience, my experience is limited. So here's Christy.
Sure, thanks. I'll just say quickly that it's a great question, and it's a topic that's receiving a lot of interest lately, and I would say CIHR is Canadian Institutes of Health Research are looking into the question as well and seeing if we can come up with some kind of standardized response or process or amount even when should people be paid for participating in research versus maybe not. There's a lot of issues to consider. We have to think about who can volunteer their time versus who might not be able to, and other barriers to having patients participate in research. So we want to make sure on the broader patient engagement spectrum, especially with the focus on the strategy for patient-oriented research out of CIHR, that we engage people from across socioeconomic backgrounds, that we're getting to the people whose voices that we need to hear on all sorts of projects. So I don't have a when people should be paid versus not answer yet, other than to say excellent question, a lot of conversation going around it. I think there's a movement toward recognizing that we do need to consider reimbursing people for their time when they're missing work or maybe not working, and that's, stay tuned, I guess. CIHR hopefully will have some direction for us, and I'd love to hear if other people have guidelines or directions to share on that.
All right. Another comment came in from Chrissy, who says, not to be a Debbie Downer, but she also runs a social media parent-led campaign, and she has heard a lot of complaints about the name, and they feel that it is, the people making the comments feel it is making light of a serious condition. Any response to that or any thoughts about that?
Sorry, Doug, we lost you for a moment. So we got up to campaign, negative thoughts to campaign.
Oh, so I'll just read it all again. She says, not to be the Debbie Downer, but she also runs a Chrissy also runs a social media parent-led campaign, and she has heard a lot of complaints about the name, feeling that they feel it's making light of a serious condition.
Yeah, I mean, their only response to that is, of course, that has never been the intent, and, you're not going to make everyone happy. That's the reality of it. And, again, this falls completely on me. The name of the campaign, this has nothing to do with anything other than me. This is my personal experience with Hirschsprungs, and this is, how I chose to move forward with this experience. And, I would never want to offend anybody or make light of this because I live it. But at the same time, this is just, again, my way of, handling it and in my life. And, for not everybody's going to love it, and I get that, and I respect that.
We have another parent, Melody, also commenting, saying, way to go, Liz. As a fellow HD mother, we are so proud of the work that you have done. She says, thank you for volunteering your time to making HD well known through the Shit Happens campaign. And with a name like Shit Happens, it has raised such intrigue in minds to find out what HD is. So you certainly have, the majority of people are certainly supportive, I would suspect. So
yeah. Thank you, Melody.
Just to add to that a little bit, to highlight, Liz is actually nominated to receive a Woman of Distinction Award tonight at the gala in Winnipeg, the YMCA gala, and so we all cheer for her that she'll receive the award tonight.
Yeah. Oh, that's excellent. Yeah. And Kelly has made a follow-up comment about, she says it is a serious thing, but when you live with it, sometimes you need to add some laughter in your life. You're going to deal with it either way, and a smile can make it a bit easier. So, and we've heard that from our presenting panel here. I mean, a lot of laughter in the background and having a lot of fun with this topic that, of course, Liz is living it, and I'm sure she gets exactly how serious it is, of course. So. All right. Any other? So we're sort of at the end of the questions. If anyone else has any last-minute questions they'd like to type in, we'll give you a few more seconds to type any last-minute questions or comments. But I do think it really is a great, demonstration of the difference between, again, I'll say it again, the parent experience and people's comfort level, and some people who aren't living it, the healthcare practitioners that dip in and out of this experience, the parents who have no experience, or the other families who have no experience with HD, and in comparison with those that live it on a day-to-day basis. It really shines a light on the differences, and this as a project to perhaps overcome these.
Yeah, and I'd also like to add there's quite a few things still that we are learning while we're doing this. One of the things that Christy alluded to is the responsiveness. Like, we were impressed with the fast responses that we received from the HD community, but then we've been under-impressed with our own response to the issues that were raised by this survey, and that's just reality. I think medicine right now hasn't evolved enough to respond to these kind of new ways of doing research. And I think hopefully within the near future we'll be able to respond a little bit faster and in real life.
Mm-hmm. Kelly's asking, and this is just getting into the clinical realm, but she's just asking from the within the aspect of healthcare provider involvement, is there any other research involved to help with this disease that's non-surgical? Are you aware of any sort of other options, non-surgical options that people can look into?
Well, I know that Dr. Goldstein, that Liz is working really closely with within the REACH campaign. He's working on animal models for Hirschsprung's disease, where he's trying to treat the disease with stem cells. So potentially in the future that will be a more non-surgical option. Mm-hmm. Yeah, and Liz has some more information on that.
Hi, Doug. One of the things that I'm not sure that I maybe shared enough of is that through the project that we've done here in identifying the concerns of families and really noticing the gap from the medical side to the family side, is in the last 2 years, another thing that has happened is that led by Dr. Goldstein, a special interest group of physicians from within North America are coming together to create a formalized group that's going to address a lot of the issues that have been brought forth by this study. For sure they are, this one, but also they're looking at other things, and there certainly is other research out there. Hopkins, they do a lot of the genetic research. Dr. Langer is from Toronto Sick Kids. He's working on some things. Dr. Alan Goldstein has a lab in Boston. So the really neat thing that has come from this particular project is how everybody has come together. Cincinnati, Toronto Sick Kids. We have a pediatric gastro doctor from Yale, Mark Howell. So it's been an amazing meeting of the minds on this, and we're really seeing a lot of the information sharing that is going back towards families already. We're creating a quarterly newsletter where questions and concerns that are coming up about treating Hirschsprungs, they're sort of getting together and, giving us feedback. So that information sharing, that stuff that wasn't available, and in terms of research, is all being shared and really growing. And because they are now working together, we're seeing all kinds of progression in the area of Hirschsprungs.
The reachhd.org site, which I assume would be a good place to learn about the latest research in this area?
Yes, it is. We try. I personally try to keep up with it. There's always so much happening, but yes, we are starting to really start to put a lot of stuff on the website now. Also, any of the social media sites we do share, but the Reach is really going to be the go-to point of being able to share information that's coming from the medical side.
And we did have another comment from Diane, who's asking about the issue of researcher engagement. She says they have an issue engaging researchers to participate on our parents participating in research Facebook page. Parents are very engaged, but how do we increase researcher engagement on a Facebook page or that kind of environment?
Yeah, so I can speak to that a little bit. What we did with the survey of our surgeons, we have a tool on our website for the Canadian Association of Pediatric Surgeons. That is a survey tool. So we went through their research advisory committee. They vetted the survey that we prepared, and then by an automatic email we could email all the surgeons that are members of this association and ask them for their opinion. So we got a 25% response rate, which is reasonable for a survey project, I think. It is difficult, I find, from talking to other physicians to get surgeons or doctors involved on social media. People are a little bit afraid about all the stories that are out there on people making a big mistake using social media, and especially for privacy issues. And we struggled with that a little bit in the beginning as well. There's no when we started out, there were no good policies available yet for how to deal with this. In the meantime, there have been policies written by the different colleges and even local hospitals. But that's certainly a concern, and I do think still a lot of the doctors are afraid to engage and become part of the conversation because of the privacy issues that they're afraid to breach. Yes,
the privacy issues are always can be a complicated world of fact and fiction, I think. There's a lot of misconceptions about the privacy stuff, but yeah, it's always a challenge. All right, well, I think that's all we have for questions from the audience, so why don't we wrap this up with any final comments from the panel. I know we have a lot of you. Maybe you can sort of figure out amongst yourselves if there's any sort of final closing comments that you'd like to just wrap up with before we close the session.
Okay, so again, I would really like to thank CAPHC to give us the opportunity to present our work here. If anybody is interested in working with us or getting a little bit more additional detailed information about how we did this, they can contact us through the CAPHC website. And then everybody should stay tuned for our next publication on the survey results and also the answers that we've been trying to search for in the literature and that we're trying to wrap up by the summer this year. Thank you very much, Doug.
All right. Well, it was our pleasure. And when you do get all of this work completed, feel free to give us a call, and maybe we can get you back on another webinar to get the final results of the surveys and all that information out to our audience as well.
Thank you.
All right. Well, we do our webinars every Wednesday at 11 a.m. Eastern Time, and it's always great if you can watch live, as your questions and comments really enrich the discussion, as you've seen here. We got some great comments and great engagement with our audience today. But if you can't watch live, we always do record these sessions and make them available after the fact on the Knowledge Exchange Network. And the person whose email address did register for the webinar or sign in as the attendee today will receive an email with a direct link to that recording. So please share it with whoever you'd like, and make sure they're aware of our webinar program. You can go to our website to receive and sign up to receive the email notifications of each week's webinars as well. So you can always stay in touch with what we're doing here at CAPHC. Great lineup of webinars for the next couple of weeks. Next week we'll be starting a two-part series on involving implementation science. And we will explore the challenges of moving research into practice. We will introduce the National Implementation Research Network, their active implementation frameworks, and we'll hear from Cindy Koenig, Laura Mummy, and Leslie Weird, who will share their experience using this implementation framework at the Glen Rose Rehab Hospital in Edmonton, and really an opportunity to take this kind of research that we're seeing here and see how we move it into practice, really a structured process for doing that. So that should be a great two-part series for the next 2 weeks. And following that, on May 27th, we'll have the first episode of a three-part series on patient safety. The first session's titled Patient Safety After 15 Years, The Disappointments, Successes, and What's on the Horizon. And we'll be bringing Dr. Trey Coffey and Dr. Kave Shojanya, who will give us a sense of what the patient safety movement's been doing for the last 15 years since it really started. Sort of what have been the successes and maybe some of the disappointments. It'll be an interesting session. And it's really about how we get patient safety back on the minds of all of our stakeholders in the healthcare system. CAPHC does have our Patient Safety Collaborative that has a monthly webinar, but that's really focused on some real nitty-gritty patient safety and quality topics that's really involving the experts. This series is meant to get patient safety back on the minds of all of our stakeholders, since everyone can play a role in safety, including our patients and families. And this is a three-part series that we have been able to produce thanks to support of our colleagues at Icaria, now part of Mallinckrodt Pharmaceuticals. So we thank them for their support. That's just the first episode in that three-part series, and we'll have more information on the subsequent parts coming soon. But again, always go to our website to check out that information. So some great stuff coming in the next few weeks, and we hope to see you back here next time. Thanks, everyone.